I got a very controversial topic last 2 sessions back about N-acetyl cysteine and taurine, and now I have another little bit of a controversial topic, which is tough calls in dual care. Who leads, the diabetologist or a nephrologist? So I think if it was a nephrology conference and I was presenting this topic, it will have only one slide. Nephrologist does everything and that's it. But because it is a diabetology conference, I will be more balanced in terms of what we do in terms of who should take the lead and all. So coming on to couple of cases so that we get into the context of this presentation. So this is a case, this is an actual case, a 52-year-old bank employee with a long-standing duration of diabetes post combined liver kidney transplant. So he had a renal failure as well as an advanced liver disease. So he had a combined liver plus a kidney transplant, and post-transplant he actually had a progressive weight gain of around 114 kgs. His baseline weight before the transplant was around only 80 kgs. So he was on steroids and other things. So this was a problem, and so he goes to a diabetologist and he is prescribed, because it is a fashion to prescribe tirzepatide as prescribed injection Mounjaro, and takes only 2 doses. And he has 7 kg weight loss in 10 days, and he reports to the nephrology clinic with serum creatinine of 1.6. So his baseline is around 1.2 milligram per deciliter. So I think the image on the right side basically shows what we basically are nowadays. We are all working in silos, so we don't know what the other person is thinking. This is the case not only with a diabetologist, but a nephrologist or any other specialty for that matter. We rarely communicate with each other. So I'll come back to this case, but this is another case. So the first case, probably the diabetologist did not communicate enough, and the patient was very unhappy about the result because his life depended on the transplant. So he obviously had to have a normal kidney function, normal liver function. He cannot start a molecule which might lead to, he was not told that there might be a dramatic weight loss, and he became dehydrated and his creatinine went up. So this is actually another case, again a post-transplant. A 37-year-old lady is actually a wife of a doctor in our hospital with early onset diabetes, post-pregnancy focal segmental glomerulosclerosis, and progressed to end-stage renal failure. And the patient underwent again kidney transplant 1 year back. And now she had, after the transplant, she had a labile diabetes with HbA1c more than 10. I was managing the patient, and I could not control her blood glucose levels. So it was becoming a big problem for me. At the end of 1 year, I sort of gave up and referred the patient to a diabetologist who did a CGM and then started the patient on an insulin pump, and then the diabetes is well controlled now. So the fault is obviously mine. I thought I could manage the diabetes for this patient, but unfortunately or fortunately for the patient, I referred the patient to a diabetologist, and the patient's blood sugar is now well controlled. So these 2 situations, the first one, the diabetologist did not actually confer or talk to the nephrologist or the liver surgeon before starting a new molecule, which might be a little risky in patients who have had a very sort of a complicated transplant, a combined liver plus a kidney transplant. And the second case, the young patient who needed a very intense control of diabetes, actually I could not control it very well with whatever I did, and ultimately an insulin pump was started, which is very appropriately started by the diabetologist, and the sugar was well controlled. So what really happens is the patient is confused. We think of ourselves as know all people, and ultimately what happens is the loser is the patient. They're either lost, confused, whatever they are, but ultimately they are the loser. And so has anybody looked into, is there any evidence as to who should manage what? And I could not find in terms of endocrinology or diabetology, but definitely for a nephrology perspective, there is a paper that was published in 2013 in terms of diabetes and renal disease, who does what. And this was actually a study that looked at patients in UK. It is not data from India. And they found that when patients who were followed up with nephrologists, they were younger, they had a lower GFR, eGFR, means their renal function was much less severe, and but they had the highest degrees of proteinuria and albuminuria. So that was what they found. And the nephrologists were following up majority of the patients with stage 4 or stage 5 CKD, and only 1/3 of the progressors were followed up in a nephrology clinic. So those who are actually progressing, 2/3 were not following up with a nephrologist. So that was a problem that they found. And again, they sort of recommended that the best outcomes always happen when the care is coordinated by a multidisciplinary team. It has been said in multiple studies and guidelines. And in the UK, it is a primary care coordinator. That doesn't happen in India, but definitely if you have a primary care person, he would be the best person to coordinate the care with inputs from both nephrology and diabetology or endocrinology. As the disease evolves, basically the leadership in terms of who should manage that patient might change from endocrine or from endocrine to diabetes, or say diabetes to diabetologist to a nephrologist, or vice versa, especially if the kidney disease progresses or if there are new metabolic or endocrine issues. So we really need to adopt an approach in which the rate of decline of the renal function, it forms an important determinant. So we don't really look at it. We look at individual values. We look at creatinine, say 3 months back, now look at creatinine, we look at HbA1c 3 months back, and now we really do not correlate many a time and then decide who needs to take a lead in terms of managing these patients. So why is it important that we should look for patients who are having a rapid decline in GFR in patients with diabetic kidney disease? We know that poor glycemic control, severe albuminuria, all these lead to a rapid decline. These are all risk factors for rapid decline. And also sometimes what happens is treatment with ACE inhibitors and ARBs or SGLT2 and finerenone initially might lead to a decline in eGFR, but it might stabilize at a later rate. But if there is a 30% decline in GFR, you actually have to stop these drugs. And there is presence of comorbidities like obesity, hypertension, and dyslipidemia, which also contributes. And then you could have patients who have undiagnosed renal artery stenosis, development of DKD over a patient who already has underlying chronic kidney disease due to other reasons, acute kidney injury episodes, as well as genetic predisposition. So these are all risk factors for rapid progression. So these are all patients who should be referred to a nephrologist early. And why is it important that we should basically have these patients being identified and seen? Because these patients have an increased risk of cardiovascular disease. They reach end-stage kidney disease early and they might need dialysis. They actually have a high all-cause mortality. So we need to identify patients who have a rapid decline in their eGFR, and these are the patients who need to be monitored very closely and also need to have a uniform and intensive care. So this is a group of patients that the diabetologist should actually refer to a nephrologist early. This is one group. The other group, vice versa, is a group where glycemic control is extremely important. We know that albuminuria risk reduction with intensive diabetes therapy, this has been proven in multiple trials like the DCCT trial and the EDIC study. And we know that intensive glycemic control is extremely important. And that is a situation where if you are not having an intensive glycemic control, a nephrologist should refer a patient to a diabetologist for better control. So both situations is what we should know, where the reference should happen, and are there any guidelines? So definitely there are guidelines. We have these guidelines which is combined ADA plus the KDIGO which is Kidney Diseases Improving Global Outcomes, which is a nephrology sort of a guideline. The American Diabetes Association is a consensus report. So definitely the leadership in nephrology and diabetology has said that okay, you should combine together, come and see the patient together, have consensus, and then give the treatment to the patient. So it basically states that leadership shifts should happen when there is a clinical need. That is the first thing. And the best care is when there is coordinated, flexible teamwork. And also the patient should also know that there is a main point of contact. They should know that okay, this is the doctor to contact when there is a problem. So that is very, very important. And then you have to understand which are the key principles when you manage a patient as a nephrologist or as a diabetologist. You need to know who controls the main disease process. That is very important. Is there a special situation like I mentioned in this case, which is a transplant? Is there a special skill or a knowledge which is required? For example, a diabetologist would be more proficient in actually using an insulin pump, not a nephrologist. And in certain situations, you might need sort of evaluation further by a kidney biopsy or something. So if you have, say, a severe hyperglycemia or a type 1 diabetes, it's always better that the diabetologist takes a lead. And if you have chronic kidney disease progression with uncontrolled hypertension or progressive albuminuria, these are situations when the nephrologist should take a lead. So one of the most important things is you should identify what is the primary problem that is driving the disease. So that, and then you let either the diabetologist or the nephrologist take a sort of a front seat. And then you should also identify if there is an immediate risk. Immediate risk means is an urgent threat, like if you have a patient with diabetic ketoacidosis or an insulin pump failure, immediately the endocrinologist or the diabetologist should come into the picture. Is there a life-threatening event like a fluid overload, pulmonary edema, urosepsis, then the nephrologist should come to the fore. And does the patient need an urgent procedure like a coronary event? In that sort of a situation, both have to come together and work together with the patient and get the best outcome. So the immediate risk is also another principle that we need to sort of look at. And then you also need to look at the local context and the trust. Sometimes the patient has a trust with a particular doctor. It might be a diabetologist or a nephrologist. I think they should basically take the lead in all the situations because the trust is maintained. And who knows the patient better is what you should always ask in your mind. And then local protocols might be there, it might be different in different places. Joint clinics with nephrology and diabetology definitely helps. And it is very important that there is a shared responsibility. And many patients actually need both the specialists to come in. And we should also keep in mind the medico-legal implications. You might be able to manage chronic kidney disease in early stage or mild albuminuria, but sometimes if something goes wrong, they might go to court and then you might land up in a trouble. Similarly, you have uncontrolled diabetes, a nephrologist is actually managing that patient and patient has a complication related to that, that also might be a problem. So I think it is very important that you have a shared responsibility, especially from a medico-legal point of view also. And one of the other key principles is actually communication between the different groups of doctors. Very, very important to have clear roles and document that this patient has been seen by the other doctor. And we should always try to avoid contradictory instructions. Shared care plans should always be documented. So that is also very important in terms of how you manage a given patient with, say, both renal as well as diabetic problems. So there are all certain examples that I have mentioned, but I think we have to take every patient or every case in a case-to-case basis and then decide who basically takes the lead. For example, if you have somebody who has type 1 diabetes with a diabetic ketoacidosis and acute kidney injury, it is very important to control the blood sugar initially. So the endocrinologist or the diabetologist might be the primary person. If you have an advanced CKD, obviously the nephrologist should come. Post-transplant diabetes, again, nephrology plus endocrinology. So you really have to look at the clinical situation and then decide who really takes the lead. So these are all certain examples of that. And then you have basically have to have a comprehensive view of what the patient needs. And clear leadership is very important when you want to take a call in terms of dual care with a diabetologist and a nephrologist. The primary driver, as I mentioned, needs to be identified. Immediate risks need to be ascertained. The trust with the patient is extremely important. Shared responsibility and teamwork should be the goal. Communication is extremely important between the doctors. It doesn't happen nowadays, but it is very important in getting best outcomes for the patients, and always keep medico-legal aspects in mind. So these are all the takeaways from my today. Thank you all for your patient listening.